Hello, and welcome to Live from AUA 2022, Highlights in BPH. We strive to offer outstanding educational courses and greatly appreciate your evaluations and general feedback so that we are able to continuously improve our programs. We thank you for joining us. Before we get started, we'd like to go over a few items. I'd like to extend a special thank you to our course director, Dr. Amy Krambeck, for her tremendous efforts to plan this activity. We thank you for your dedication and commitment to urologic education. Thank you as well to our distinguished faculty, Drs. Dean Elterman, Stephen Kaplan, and Lori Lerner for their time, talent, and expertise. The AUA is accredited by the ACCME and designates this enduring activity for a maximum of 1 AMA PRA Category 1 credit. The AUA is not accredited to offer credit to participants who are not MDs or DOs. However, the AUA will issue documentation of participation that states that the activity was certified for AMA PRA Category 1 credit. All persons in a position to control the content of an AUA educational activity are required to disclose any relevant financial relationships with any commercial interest. Please visit AUA University to view Faculty, Education Council, and COI Review Workgroup disclosures. The AUA would like to thank Cook Medical and Olympus Corporation of the Americas for providing independent educational grants in support of this activity. This activity is meant to be educational in nature and in some instances reflects the opinions of the presenters. The information does not guarantee accuracy of claims submitted. Please verify the accuracy of individual medical claims submitted and please follow individual insurers' rules. Finally, thank you for attending Live from AUA 2022. I will now turn the program over to Dr. Krambeck.
Thank you for joining us for Live from AUA 2022. Today we will be discussing highlights from the AUA annual meeting BPH presentations. My name is Dr. Amy Krambeck. I am Professor of Urology at Northwestern Medicine in Chicago, Illinois, and I am honored to moderate this informative discussion that we will have here today. I'm here today with three specialists. We have Dr. Dean Elterman. Dr. Elterman is an academic urologist at the University of Toronto, subspecializing in functional urology. His clinical and research interests include voiding dysfunction, particularly sacral neuromodulation, benign prostatic enlargement, and men's health. He is the medical director of the Prostate Cancer Rehabilitation Clinic at Princess Margaret Cancer Center. He lectures internationally on the topic of novel technologies for BPH and sacral neuromodulation and teaches courses at the AUA and SIU. We also have Dr. Stephen Kaplan, who is very well known. Dr. Kaplan is professor of urology at Icahn School of Medicine at Mount Sinai and is director of the men's health program of the Mount Sinai Health System. He is a serial entrepreneur and founder of the Metadate Solution Incorporation, a publicly held corporation and one of the premier electronic data capture companies in the world. He also has interests in medical informatics as well as Inspirin and a digital interface analyzing and enhancing patient experience in healthcare professionals. Dr. Kaplan has been a member of many professional organizations, over 30, and he's been awarded 5 NIH grants and has received over $13 million in research funding. He was awarded the John K. Latimer Award for Lifetime Achievement in Urology by the National Kidney Foundation. He is the founder of the Society of Benign Prostatic Diseases, and currently he is the chair of research of the American Urological Association and is one of the AUA BPH Guidelines committee members. He's a busy guy. Finally, but last but not least, we have Lori Lerner. Dr. Lerner is an associate professor of urology at Boston University and chief of urology and deputy chief of surgery at the Veterans Affairs Medical Center in Boston. She is also the current chair of the BPH Guidelines Committee. Dr. Lerner is an expert in male voiding dysfunction and prostate surgery. She's fellowship trained in HOLEP. She's been an academic urologist her entire career, and she's been involved in teaching HOLEP to residents and urologists at home and abroad for over 20 years. That is a huge achievement. She is a strong advocate of education about surgical energies, particularly laser surgery, and has been involved in numerous initiatives and courses promoting education and training. It's going to be a great discussion. I would like to start by just discussing the scope of the problem. BPH is highly prevalent, and lower urinary tract symptoms increases with age, as most of you know, such that about 50% of men over the age of 50 experience symptoms, and approximately 80% of men by the age of 70 have significant symptoms. With improvements in life expectancy, BPH affects a large proportion of men globally, and its prevalence is increasing. Because the condition is so prevalent, there are many treatment options available ranging from biofeedback, medications, office-based therapies, surgical interventions. Cost modeling indicates that early intervention is beneficial. However, exactly what intervention is somewhat difficult to determine since there's so many options available. Making a treatment decision really depends on patient preference, longevity of the treatment results, side effects, prostate size, cost, equipment available, as well as the surgeon-specific factors such as their comfort level. We hope that today's discussion will shed light on current available treatment options and their respective indications and benefits. So, after that introduction, I think we should start by focusing on the new AUA BPH guidelines, how to best diagnose and most effectively and safely treat BPH. Dr. Kaplan, you were the course director for this instructional course at the 2022 AUA, as well as an author of the recently released BPH guidelines. Can you please explain how the new guidelines are structured with regards to the diagnostic evaluation of mLUTS and the notable differences in the current guidelines compared to the prior versions?
Sure, and Amy, thank you very much for the kind invitation to be with colleagues here who we interacted a lot over the last 4 or 5 days. So I had to give a lecture about how diagnoses have changed since the original guidelines, and frankly, not much has changed. We still actually talk to patients and ask them what's bothering them, and that's probably the most important thing to help guide us. We have some objective measures, which things like uroflow, post-void residuals, rectal exam, and the big change that's occurred is really whether we measure prostate size, because that helps herald for us what type of treatment should actually be done. But the bottom line is, as it's always been, you got to listen to the patient, what their type of symptoms are, and that will help guide us to the best types of diagnosis and treatment.
I would completely agree. And I think adding size is really important, especially given the vast options currently available.
Yeah.
The updated guidelines recognize the role of several new office-based treatments for BPH. In your opinion, what is the simplified approach for the urologist in determining which one of the many office-based treatments is right for their patient?
Well, the good news is, in a sense, the challenge, because now we have a panoply of things to offer. It's really a question of what the predominant type of symptoms the patient has, what other concomitant conditions they may have, in trying to fit. And a lot of it has to do, frankly, with prostate size. That's a biggie. And as you mentioned before, and I'm sure both Lori and Dean will talk about this as well, that if prostate's really too big for what we think is a good result with a minimally invasive procedure, then we don't really use them. And you can argue and debate whether it should be 20 grams or 30 grams. Most of the guidelines will say 30 to 80 grams. So if we're going to think about that in a patient, in other words, they're a patient who either A, doesn't want to take medication, B, has taken medication, hasn't worked, can't tolerate it, and is willing to have a procedure, but they don't want to have surgery, then we think about the three that, at least in the United States, are FDA approved. And then prostate size and configuration are important. I mean, from my perspective, I think there are certain times I will do one versus the other, and I'll let my colleagues here discuss which and when and what they're going to use. But prostate size and the presence of a middle lobe can help determine which of the types of therapies you have. And I'll have a full discussion with our patients and try to figure out what's important to them. In other words, for some patients, they like a stepwise approach. They don't want the one and done. And for some patients, it's a one and done. Give me the procedure that you think is less likely to be a retreatment. And that will begin to have the discussion about which direction we go in. But it's very open, very engaged, and we try to empower patients that they have a good idea about what their choices are going to be.
That is a great way to think about it. And, with the newer mist therapies available, one of the benefits is preservation of ejaculation. And, there's so many different options. How should the practitioner think about the trade-off with maximal improvement, avoiding symptoms while preserving sexual function? What is the approach that we should be taking for this?
Well, it's interesting. We've made it about ejaculation, but one would argue, and I'm sure Lori and Dean will, is that even with some surgical approaches, many surgical approaches, you can preserve ejaculation as well. So many of the advantages may not be with regards to ejaculation. From my perspective, the major differences are a missed therapy it's a quick procedure, and in my world can be done in the office. So you take essentially a 5-minute procedure. They're done in the office with either some sedation or whatever local anesthetic folks like to use, and they go. And that's a major advantage for patients. They can go to work relatively quickly, and they don't have as much downtime as they may have with surgery. So that's a big guide of it. My perspective of ejaculation, many of them come in with that notion that, well, if I do this, I'm going to be able to ejaculate. If I do surgery, I won't. But that may actually be true. So for them, it's really a question of what they're willing to tolerate at the beginning and the outset. And yes, we have a discussion about ejaculation. It's important, but the differences between the therapies may not be as big as we think.
Amy, can I just add one thing on this topic? 2 takeaways for me from this AUA is, number one, to recognize there's actually a baseline prevalence of men who have ejaculatory dysfunction just out there in the community, regardless of whether they're on an alpha blocker or not. There's many men who just with age have ejaculatory dysfunction. So you should ask them about that at baseline. And number 2, you shouldn't necessarily have this assumption that as men age, they care less about their sexual function, ejaculatory function. So there may be many younger men who frankly wouldn't care if they lost it, but there may also be some men in their 70s and 80s who will care very much if they lost it. So those are 2 takeaways, at least that I had from this meeting.
I think another point is that men often confuse sexual function and what that actually is. For some men, it's an erection. For some men, it's their libido. In other words, they don't have desire, and then they think, well, give me a Viagra and my desire will get better. It doesn't work that way. Ejaculation is a third component. So really trying to understand what their concerns are, what is important to that particular patient is important, I think, in terms of how to guide which type of therapy we want to use.
Go ahead, Amy. Oh, I was just going to add to that. I think for some of these as well, a lot of men just simply don't understand what ejaculation means. So trying to help them understand it or characterize it. And sometimes that can even be done by giving them a trial of medication that will actually do that. Like, we won't necessarily leave them on it for forever, but maybe it gives them a better idea. So I think they hear loss of ejaculation, and just like Steve was saying, in their mind, that may be loss of erections, that may be loss of libido. They don't always really, or that they're not going to be able to attain an orgasm. So I think it is important for us to spend some time saying, no, you're still going to be able to climax, and try to really make sure that they understand exactly what we're talking about, because there is so much direct-to-consumer marketing that it raises up in their brain, but they don't always actually know what it is that means, or they interpret it wrong.
I completely agree. The doing HOLUP has opened my eyes to the whole realm of varying degrees of sexual function and what's important and whom. And we could talk 2 hours on this. But as all of you were talking, you brought up medication. Dr. Kaplan, is there anything new in the guidelines with regards to medical therapy or medications that we should be aware of?
Well, since the last guidelines that we did on medication, there have been a lot of combination therapies, as well as the advent of the use of bladder agents, either in combinations or as monotherapy. So there really hasn't been a major flip in alpha blockers or 5-ARIs. The use of tadalafil, we addressed whether as a monotherapy or as a combination therapy. The use of medications like anticholinergics for patients with predominantly storage symptoms, again, either monotherapy or combination therapy. And also we began to talk about the beta-3 agonists, which evolved over the last 7 or 8 years. So there are a lot of different types of medications. I think one area that we're going to have to look at is how we define failure with those therapies, not much as well as missed therapies and surgical therapies. It will be something we talk about a little bit later, but that's going to be important, particularly with medical therapy, because what I may define as a failure, you may not, and more importantly, the patient may not. So we have to kind of put that together as well.
Excellent point. You touched on that the AUA guidelines is a very extensive document, and most people are not going to be able to commit it to memory. How do you suggest someone utilize that in their daily practice?
Again, pragmatic. So you're not going to go through every part of it, and frankly, a lot of things may not be relevant to a particular person's practice. They may only do one type of mist therapy or one type of surgical therapy. So the indications, if there's somebody who does primarily bipolar vaporization, what all the comments about thulium laser may not be that relevant to them. I think the most important part is diagnosis. And at the end of the day, regardless of which therapy, the diagnosis should be made in the same way. And I think the concept of using some type of measurement of prostate size, if you're thinking about doing something, are the major differences between what we have today and what we had years ago.
And I like to add that I think that people focus on the statements. There is so much knowledge to be gained in the supporting text. So I think what people don't necessarily look at that, they're looking for these little bullet points. And if they're not getting that from that particular statement or whatever statement it is that they're looking at or subject, really they should go in and look at the supporting text, because every person who took on that guideline had the opportunity to expand, and it could pull in literature beyond the randomized controlled trials or whatever it was that we required or found that we needed for generating the guideline statement itself. But we could pull in all sorts of other things to talk about the technology in the supporting text. And I think people just don't read it. I mean, it's an extensive document. So I encourage people to look, because that's where the meat of where we got some of that information, but we also build on that too and dive and become a little bit more granular. And also the algorithms. I do think the algorithms are helpful. And that's another quick little bullet, at least for sure in the management and workup algorithm and medical management. I find that one, to be a nice little nutshell to have on your phone as a quick snapshot.
Excellent point. A lot of great pearls within the text if you have time to read it or are looking for something specific. Just to change gears a little bit, the guidelines endorse laser enucleation as a size-independent treatment option for BPH. It provides limited information on newer forms of prostate enucleation called bipolar nucleation. Dr. Elterman, Dr. Li-Ping Zhi highlighted his surgical approach using bipolar enucleation in the semi-live session. Based on the presentation, what do you see are potential advantages to this technique?
So I think we all accept that enucleation is often seen as an energy source independent technique. And it can be done with a variety of lasers, tools, and bipolar electrocautery or electrovaporization. Dr. Xi presented a very nice video with some of his data looking at something that I think he's developed in China, which is called the Dayu scalpel, DAYU. And it's based upon a harvest sheath, a harvest farming implement from about 500 years ago in China. And essentially, it has three modes of action. It's shaped almost like a sickle, and it has the ability both to get into the plane for nucleation and push tissue away. It has a bit of a point on the end where you can apply focused electrovaporization or electrocautery for a hemostasis, but also has a sharper side where you can actually resect or electrovaporize tissue. So it almost has a 3-in-1 approach. And it really demonstrated, I think, the versatility not only of enucleation, but the versatility of this particular instrument, where he can very quickly use the somewhat sharp edge to get into the tissue, use his scope and the front edge to push away the tissue, and then, of course, provide cautery. And if he wishes, at the end, to either resect or morcellate. But of course, it just showed the versatility of what he was doing. And much like all enucleation, regardless of energy source, it looked very nice and a great end product.
So do you adhere to the statement enucleation is enucleation is enucleation?
I might ask you and Lori what you think of whether enucleation is enucleation. But from where I sit, looking at all the various excellent videos presented at the AUA 2022, it does seem that there are a lot of commonalities between enucleation, of course. It seems like it's an expert technical skill. And then I think you get a little bit into the weeds in terms of the nuances between perhaps the different approaches, whether it's 2-lobe, 3-lobe, on block, early release, and of course the energy source.
I think what's really vital is that people understand their energy source. So I think this came up that we know that we can do endoscopic enucleation with other energy sources or other approaches. Just because we can doesn't mean we should. And at this moment, we don't have the right answer as to whether there are preferred energy sources. I guess what I would say, what is so important is I don't think we do a great job. Obviously, this is my passion. I don't think we do a great job in residency programs of really training people on the different energy sources and tissue interactions and what the harm they could provide, quite frankly. And so I think that there's a belief that if you've gotten used to one, at least in the laser world, a laser is a laser is a laser. And we know that in actual fact, that's not true. So I guess I would say that while we may not have identified if all of them should be used, and that may be fine, but mostly ensuring that whatever energy source you use, that you understand what that tissue interaction is going to be. So you don't heat up the bladder too much. You don't blow apart the bladder neck. You don't go deeper into the capsule than what you intended. Just really understanding how it interacts. And if you do, and you take the time to learn about that, then the most important thing is just doing it safely.
It seems like in the realm of endourology, we often try things and then a year or two later, we step back and see what are the potential complications to it. And it may be that way in oncology and other areas as well. But I do, since I'm an endourologist, I see that. But it does seem like the bipolar technique does have some significant advantages to it. Dean, do you see any potential negatives to it?
I think, well, his particular technique seems to be originating in China. So obviously it's this whole concept of dissemination of technology. Some technologies are really regional. There's a lot of certain types of surgeries performed in Europe that aren't really done a lot here in North America and vice versa. So I think that may be part of it. And again, it's just sort of the learnings. But one of the advantages, I think, to this particular dye-use scalpel technique in bipolar is that it does seem to transfer over a little bit more easily to people who are very familiar with using that type of resective technology.
I've done button enucleation when I've done my surgical work in Malawi because I'm not able to bring a laser or any of that with me. So the only technology I actually have available to me is a button or a loop. And I guess I would say it's a little bit harder to see the capsule, so I think it's just understanding that. And you don't want to go too much deeper because you just don't, because you definitely don't want to cause bleeding. I'm not in a place where there's 3-way irrigation. So I think that's the one difference I would say. I tried it with a loop because I had loops there too, but I found for me, at least, it was easier with a button, but I didn't have that same clear look of the capsule that I'm so used to with holmium, but I could get a nice big defect.
Fantastic. Well, I think that parlays us into our next question, which is, Dr. Lerner, you were part of the new hands-on skills training course that we had at the AUA this year, and it featured multiple different therapies for ablation or removal of the adenoma. And based on your participation in this training, should we be incorporating all of these different therapies into our practice as a general urologist? Where should they be focusing their efforts?
Well, I think what I see from year to year is that there still seems to be either some deficit, something that we're just not quite meeting in what we have, that there continue to be new technologies that come down the pike and people adopt them. So I do think that we pick the ones that we like. I guess I would say, should we? Well, I think patients expect that every practice that they go to is going to have something that is cutting edge. I think it would be hard to not expect that. I think there is this sort of expectation that there's the tried and true, but that your practice is also on the cutting edge and you're doing new things, modern things, novel things. And I think patients want that and look for that. And if you're not presenting that forward, then you run that risk of those patients going elsewhere to seek out that therapy. Now, we also have to caution ourselves that we shouldn't be doing them just because that's what the patient is asking for. So I do think there's fiscal responsibility. And I think people need to kind of like look at their practice and then look at their community. Like here in Boston, we have 5-6 different people that do enucleation. So if you've got one large or extra large, super large prostate that comes into your practice every 2 to 3 months, do you really need to learn and adopt how to treat these really big glands? That in that community, that doesn't make sense. And so you may focus your practice on that other group that you see mostly, and that is your general population. So I think it's important for people to look at what's in their community, what's coming into their practice. But I do think that there should be some sort of tried and true and something modern that is being offered, because I do think that's what people are looking for.
So one of the challenges that occurs is we get as what's the best, and the best is what you do and do it well. That's the best. And I think that often we get caught up in these types of interesting discussions. So from my perspective, even though holmium nucleation is not done as much around the country, if I needed one, I could come to either you, Lori, or Amy, and I know I'd get a great result because you're committed to the technology, you're excellent at it. But that's really, are you the rule or the exception? And that occurs, frankly, with all these technologies. And I'm a big believer that do what you do it well, make the right diagnosis, and you'll have a very satisfied patient. The sheer reality is that the TURP, a monopolar TURP, is still the most common procedure done around the world. So, it's not a terrible procedure. We do have a lot of options here, and that's a good thing. It's just we should really focus on getting back to right diagnosis and then doing a therapy. If they were missed, get good at one of them, and a surgical therapy, get good at one of them, and I think you're good to go. And I think if the patient has a good result, that's really at the end of the day what we want.
So, Dr. Elterman, Dr. Kaplan is, I think, saying do something really well and maybe have one base surgical procedure that you're doing well and potentially incorporate in a missed therapy. You do quite a bit of various different treatments. What are your thoughts on that?
I think for those of us who are very passionate about new technology in BPH, it's kind of fun, and it benefits patients, frankly, and residents and students to be able to try out these different technologies, evaluate, assess them. I would agree with Steve that if you are in a general practice, having a few things that you're really good at, tools, are what you should have. So if you are great at doing a bipolar TURP, and that's how you approach your bigger glands, that's excellent. And if you would like to have a mist, there are various mists to choose from. As enucleation is in a set of hands that are expert. We now have other technologies coming out like aquablation, which really offers the ability to treat a wide range of prostates in terms of size and shape, maybe with less training or skill sets. So as these new technologies come around, they can often permeate through the community perhaps a little bit easier compared to other technologies. But I do think sort of it's incumbent upon us to offer our patients at least a few options and not just say, you have to have this and no other choices.
Well, there's also a difference between being at an academic and a training center and then a large practice sometimes outside of that. So I think it's a different environment, an environment like you're in, Dean, or actually the four of us are in. The expectation is that we would be able to be cutting edge, as the case may be. But in the real world, which is the rest of the world, and which is most of the world, they don't have that ability to offer 3 or 4 different things or 5 different things. And I think the patient expectation is different. Certainly coming to one of us, I think the expectation would be to be more cutting edge, for sure. I completely agree.
So I just want to circle back one more time. So Dr. Lerner, you had briefly touched on cost. A lot of these treatments require very specialized equipment, and this can be highly costly. Furthermore, the reimbursement is constantly changing. Any words of advice for the general urologist who's trying to weigh cost and quality? Um, any suggestions?
Well, I work at a VA hospital, right? So everything that we do is paid for by the taxpayer. We have a very high accountability because we're accountable to our patients, but we're also in theory accountable to everybody, right? The entire population. So I believe very strongly in fiscal responsibility. And we do a lot of things in medicine that are expensive, and that is an expectation. And where all of us practice is that is going to be available, but it drives healthcare costs up, and that overall hurts America, right? It hurts society, period. So I'm not necessarily a big proponent of doing really expensive things for the sake of doing expensive things. I think I will go back, if I'm talking about in the non-academic setting right now in the community, which is what Steve was talking about, is what is in your community? Is there a deficit in your community? Is there something that your hospital can provide that the hospital down the street isn't providing? Now, I don't think that this should be that. I mean, to some degree, we're all competing with those hospitals, but at the same token, I think that we should, as urologists, be collegial and sharing, and exactly what we were just talking about. We might offer something here, but we should also not be afraid to refer to our colleagues for something that they might offer, and that this is a way to keep costs overall controlled and down. As far as whether or not there's a technology, I mean, aquablation is a one-trick pony, right? So, maybe that doesn't make sense for everybody. It would if you're in a high volume place where the difference between doing 2 cases a day and 4 cases a day is big. That's huge. You could get patients through faster. That may make sense. If you don't have a stone platform, it may make sense then to say to your hospital, okay, I'm going to look at Moses or Holmium or TFL, something that can do multiple different things. I just don't think it should be a knee-jerk reaction that I need to have this. I think that people should critically evaluate what is missing and use that as their basis to determine what they should move forward with in terms of convincing their practice or their hospital.
Well, one other factor, and we're focusing, Amy, on the cost of a laser fiber or a laser machine or an aquablation, but it's also human capital, which is going to be the biggest cost addition to the American healthcare system over the next 3 or 4 years, maybe a 15% increase. So being able to do things and the throughput is faster is also important. So for example, if you had 3 patients with 150 gram glands, and you did 3 HOLEPs, and again, maybe in your hands it's going to be pretty quick, but for most people, probably take a couple of hours each one, I would imagine, if not longer. You can put 3 aquaplations much faster, so the nursing time, the OR time, the hospital time, the anesthesia time is less too. And again, that's bigger formulas than what we're used to talking about. My point is that when we talk about cost, it's not just the cost of the equipment; it's the ancillary stuff as well. As we put that together, and it's all going up, but we have to think about those perspectives as well.
Well, and access, which is exactly what is what you were saying and what Amy has said, like if you were in a place where there aren't a lot of urologists in your community and being able to get patients done without having really long waiting lists, I mean, Dean can probably respond to some of that, then some of these technologies do make a lot of sense. I just would caution us that just because we can do a particular size, shape, morphology with a technology doesn't always mean that we should, and we can't fit everybody into one thing. And I think that's what all of us here would say. And that goes back to where you started with this whole conversation, which is, should you offer more than one technology? Yeah, I don't know that you need 17 technologies, but in this day and age, ideally, yes, we think that it would be nice for you to have something that fits that patient instead of making the patient fit the technology. Find the technology that fits the patient.
Yeah. Great discussion. Talking about the different technologies, Dr. Elterman, you were part of the surgical BPH course as well. Anything stand out from your perspective with regards to potential complications of the various therapies that we should be aware of or concerned about? Anything unique that you would like to highlight?
Well, I think no technology is without complication, and anyone who tells you otherwise isn't really being truthful. So, I think that each of these technologies has their own unique attributes and thus some unique aspects in terms of possible complications. This really great hands-on ablative resective course really demonstrated not only how to set up these devices with real models, but also just an opportunity to discuss with participants what to expect when they're doing surgery and the complications. So we had at this course, we had aquablation, resume, water vapor ablation, and enucleation, if I remember correctly. So, the complications for each of these are well known. For me, a couple tips and tricks that I glean from rotating around. So for resume, for example, I think one big tip for individuals is to remember not to overtreat. It seems like it's very easy just to give more steam. It's free. Why not give another injection of 9 seconds of vapor, or 2 or 3 or 4? But pretty soon it adds up and it's not necessary. And in fact, we've shown in some recent research that less is more. In fact, less steam, single injection or 2 injections, results in just as good as of an outcome. And in fact, there's absolutely no relationship between how much the prostate shrinks and how much steam was injected. So that would be a takeaway from there, because you can get complications in terms of necrosis of tissue. With the aquablation, complications can be everything from just, I think, getting very familiar with ultrasound. It's not really a complication, but it's more of skill that's necessary. A lot of people, I think, don't appreciate the level of education we all get with transrectal ultrasound and imaging. And this is an imaging-based technology. So just being able to really see the prostate, map it out not only with the software on the screen, but in your mind, 3-dimensionally, is a key attribute. And then, of course, with enucleation, I mean, I think Amy and Laura, you can talk at great length about this, but those hands-on courses really allow you to sort of understand how to get into the plane and stay in the plane, because of course you have the potential complications of losing your space within the prostate as you're enucleating.
Well, that really brings us to the next question, which is, how do we learn these techniques better? We did have a couple of new models in the ablative course. They're definitely a start in the right direction. Do you think that simulation is really going to be able to teach people enucleation? I think the simulation for the resume in the aquablation is really lifelike, very good. But simulation for enucleation, I don't know if we're there yet. What are your thoughts?
Well, I think one of the challenges with enucleation is that unless you're learning it as a resident or fellow, you're going to have to learn it mid-career. And then you sort of have this issue of, well, where do you go to learn? How do you learn? And how do I ethically practice on my patients? As if, when a resident, they weren't your patients, but still you have to practice on a patient. So these models allow surgeons to at least get the basic steps down, the ability to understand how their hands move, how to interact with the tissue. And of course, these models have gotten better compared to the ones that were around 5 and 10 years ago. So I think we're definitely going in the right direction. I think nothing replaces real human practice and training on a patient, but these models that we had at the ablative course were very helpful, I think.
I think simulation is a bit of a mixed bag. I think the benefit of simulation is, just like Dean was saying, it's just getting used to the equipment and how to move your hands. There's a haptic feel to all these things that you can't quite get with in the simulators, no matter what you try to do. What I've worried about a little bit with the enucleation models is, if you spent a lot of time on that, you have this impression of the tissue interaction, and then you actually go into the patient and that tissue interaction is different. And so whether your dwell time is longer or shorter, spending too much time in a simulator could actually give you this false sense of how things are supposed to go. And you actually could either not be very efficient, or you could actually dwell too much and cause a little bit more injury. So I think, in my opinion, just my opinion, that the best thing about the simulators, especially for like resume and urologists, is just knowing where the buttons are. Like, get used to the handpiece, how you need to turn the handpiece, find the gray button when you want to release it, retract it, prime it. Just get comfortable with that, so you're not spending all this time, getting yourself right set up in the right position, like a urolift is classic, and then turn around and have to look at it and you lose exactly where you are again. So I think that is really important. And I think with the nucleation, just feeling the scope and how to make the moves, just like Dean was saying, and the steps, but trying to get through to people that the interaction, the tissue interaction is not what you should be focusing on. It's the steps and the motions and the equipment.
So that leads to the opportunity or the changes of learning techniques that are easier. Because if you have to do a lot of simulation to learn something, then the one that needs the least simulation and or the least experience and technique maybe wind up being more popular. So for example, Dean alluded to before aquablation. It's a very, 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 very easy technique to learn. In fact, residents are with me, and after 2 or 3, they're able to do virtually everything except programming. And I can't say that for any other procedure that I do, certainly not some of the minimally invasive, enucleation. I've done almost 4,000 TURs and I'm still learning how to do them because it's just a long learning curve. So if you begin to develop, and you know this is going to happen because of the nature of technology, that when you start learning techniques that are easier to pick up, they may have favor because of the learning curves being less. On the other side, to do some of these procedures, you have to have good basic skills, whether it's electrosurgical skills or laser skills. And if we wind up being totally, if you will, robotic, then we're going to lose some of those other skills that are important. So it's going to be a balance. And that would be my concern moving forward, is that can we have a future generation of urologists who will be adept enough that if that particular quick procedure doesn't work, then they can revert to some of their skills that they learned in their residency and early career that may be able to augment that.
Well, and to go to what you said initially, Steve, the other thing is I don't want us to lose sight with the, and again, this is talked about direct-to-consumer marketing, direct-to-physician marketing of what is easier to learn, therefore means that it's the right thing. So I do think that we've seen this play out in the past, right, with ablative technologies, where then the reoperate or the retreatment rate, goes up. So, which you were talking about retreatment at the beginning. So somewhere in there, it is really understanding what that technology does and applying it appropriately. And we don't yet know what the sweet spot is for some of these technologies, but in the places where if we get to that point where we identify, absolutely, it makes sense. If there's access to that technology, it's faster, it's easier to learn. By all means, we need to do it. I just don't want us to forget that it's still not that everything can be applied to one thing, and we need to accept that it could be a staged approach. Steve mentioned this before. We may accept that there are certain things that may need to be done in 5 years, and that may be okay. We don't yet know the answer to that.
It's interesting as I'm listening to you all talk. I wear my other hat as a stone surgeon, and I forgot if we were talking about BPH or shockwave lithotripsy, because we've done it in different fields as well. We can very well simplify it so that everyone can easily do it, but we may have to retreat. So it's a very common discussion. Talking about simplifying, Dr. Elterman, you had a chance to look at Dr. Chugte's semi-live BPH procedure, the iTind. Where do you see that technology in the general urologist practice, and what are the take-homes from that presentation?
Right. So I had the great opportunity to see Bilal Chugte from Cornell present his plenary talk on the new iTind temporary implantable nitinol device, TIND, that's what it stands for. And this is now the third MR minimally invasive option now on the market, along with Rezum and UroLift. And I think just a couple of things. So this is a unique implant in that it's placed into the prostatic urethra across the bladder neck. It expands and it's left in situ just for 5 to 7 days. During that time, during the expansion, it causes ischemia and ischemic necrosis, resulting in these deep grooves at the 3 struts placed at 5, 7, and 12 o'clock. And uniquely, after 5 to 7 days, it's entirely removed and the procedure is done, and you've essentially opened up the bladder outlet with this device. Now, Dr. Chugte presented a video essentially showing the newer modified technique, which allows this to be performed in an office with a flexible cystoscope. And so the insertion really takes under 5 minutes, performed with a flexible scope. You can then introduce the device through an access sheath. You place it under direct vision into the prostate where it's seated with an anchoring leaflet, and then a tether is left in place on the dorsum of the penis. And 5 days later, you backload the string, the tether, through an open-ended catheter. You advance it down to the hub, and the device collapses inside. So that was what Dr. Chugdai presented at the plenary. Where this fits in? Well, I mean, I think it's very interesting. There's a couple differentiators or advantages with this. Number one, it essentially doesn't require a catheter. The catheterization rate's of around less than 5%. It results in no ejaculatory or erectile dysfunction reported in the literature. And number two, it may be interesting in that it can treat some bladder neck pathology. With a urolift and a resume, you have to start 1 centimeter back or 2 centimeters back because you don't want clips or steam going through the bladder neck. But here you're purposely incising the bladder neck with the struts. And so for perhaps some men who have a different pathology, bladder outlet obstruction from a tight bladder neck, instead of contemplating a TUIP, you might consider an ITIN. So it differentiates a little bit in terms of the patient population. But again, I think it's going to be generally on par, 30 to 80 gram prostates compared to urolift or resume as an option.
I'll be very curious to see what the retreatment rate with that is going to be. Then they may not go home with a catheter, but they're going with the string coming out of their penis.
But to your point, and I think we alluded to this very briefly, durability does not have to be the be-all and end-all for every BPH surgical treatment. I think if we flip things on their head, as Amy said, this reminds her of the stone world. Well, this reminds me of the OAB world. And, we do Botox repeated every 6 months, and it makes people very happy. And that doesn't, one Botox injection doesn't have to last for 10 years. So the idea of, as devices get less and less invasive with less morbidity, maybe their ability to be repeated more frequently may not be a trade-off that men will disagree with.
That's the science of it, and then there's the economics of it. And the challenge is what will drive. It's a big drive of what does this is reimbursement. And it's almost a taboo topic sometimes. But the reality is, and I'll give you an example from historically and how things have changed or not changed. 25 years ago, 30 years ago, microwave was a very common technology that was used. And people sounded just like you, Dean, in terms of the enthusiasm. And I was one of those people who was enthusiastic. And then it got approved, and Medicare in New York was paying over $5,000 reimbursement, which was like crazy. It was insanity. So guess what happened? Everybody started doing microwaves. And then over the course of time, insurance and Medicare said, hey, what's going on? There's a lot of retreatments. And then the reimbursement went down to such a level that it became less cost effective and it stopped being done. The data didn't change. They didn't change at all. Nothing. The science didn't change. The only thing that changed was the reimbursement and the money factor. So it would be naive to think that that's not part of it. I understand from the patient perspective, and I agree. Sometimes patients would rather have something done every 3 or 5 years. The question will be who's going to pay for it, because the cost of these things, as Lori and Amy talked about before, is not inconsequential, and companies are not going to want to reduce their cost. So somewhere something gives.
Well, and I think that was a focus in one of the panels at the SOBPD meeting that you participated in. Would you say microwave was one of the bigger lessons in the last 20 years, or maybe the interplay between reimbursement, driving technology, and then perception?
Well, it was a lesson. I don't know if it's been well learned, though, because we seem to be repeating the same things today. It would be naive for us to not recognize that a lot of things are driven by the economics on the cost side as well as the reimbursement side. And we're back in the microwave era. We just are. It's a question of magnitude and things like that. So sometimes the situations will be driven more by the science of economics and reimbursement than the science of the technology, because the technology is what it is. Now, there may be technologies that evolve over time that are, let's say, better than the current MIST therapies, and the durability may be a little bit better. So the cost reimbursement may wind up being better. But it's not ad infinitum. It just doesn't work that way. Because if people are doing a lot of something, people are going to ask why you're doing a lot of something. So you're going to have to show that there's a reason why you're doing a lot of something and that it's cost effective. And it's not just whether a patient will come in every 3 years to do it. Someone's going to have to pay for it. And that's a big factor. And well, I don't know if it's a lesson learned. It's a lesson that happened. I'm not sure we learned too much.
And I don't actually think patients want to have things done again. I mean, my Botox patients may tolerate it, but I think if we told them that we had something that they could have, not come in and have their flexible system, they would choose that. So I think this is where we have to sort of police ourselves, because 3 of those can go great, and then the next one they've got urosepsis and not so great, right? So I think we do have to be critically evaluating our outcomes, but what's also happening out there as well. I had this conversation. People are still doing tuna. There are people who are still doing microwave, and I think just like we're talking about, they're in their hands are getting good outcomes. But I think we do have to constantly say, should we be doing that? Should we be spending 45 minutes doing a procedure that may look pretty much the same with something that takes 5 minutes, just because there is risk the longer we do things? So I don't think we have the answer to all of that yet. But some of these new things that are coming down the pike actually will give us some answers about that. Actually, I think that the stents, the Optilume, these things that, if they're able to give patients enough of a symptom control and there isn't a lot of risk associated with it, it may change that paradigm a lot. Amy, you and I can get flow rates of 40 on patients, but I don't think a patient comes in and says, I need a flow rate of 40. I think if their flow rate was 8 and they got to 15 or 16, they'd be pretty happy. So, but I don't think that they want to have every 2 years regress back to 8 and then go back to 14 and regress back to 8 and do this back and forth. So I think, we see what some of these new technologies are going to give us.
That was a great discussion. So maybe, would you say, Lori, that your perspective would be to maybe wait and see what the data shows after a few years before adopting these technologies?
I think it's impossible. And no one's going to do that, right? PAE is a perfect example. People didn't care about the data. They started doing it because they believed in it. BPH is one of these things that, I think in cancer, people wait for more information, but BPH, nobody seems to care. It seems like, they're ready to inject anything and everything into it. So do I think we should wait? It's hard these trials take a long time to run. It's hard to randomize people. We all have struggled with that. Recruitment is tough. I do think, though, that we need to understand who are the right patients for some of these technologies. And we're only going to get that by starting to do this. And these highly selected patients in these trials are probably not actually going to give us those answers, right? So I think if we're responsible and industry is committed to what we're doing, and we're committed to the patient and their course when we're doing some of these things, we're very transparent that, look, this is new. I don't know, but I do know the space. I know the perineum. I know the prostate. I know the urethra. I understand in theory what this is supposed to do, and be ready to pivot. I think that's what we really owe our patients. We need to be advocating for them, not advocating for the technology, right? And through that, we're going to be able, hopefully, to get more granular and be able to say, maybe we're going to have a big chart. If you have a middle lobe this size, you're tall, you're wide, like at the stents, I think there's a 200-gram prostate can come in all sorts of different shapes, right? We talk about size all the time, but I don't think size is the answer all the time. Very wide prostates are different than very tall prostates that aren't as wide. A bilobar versus a trilobar. So I think we're going to start to get into the weeds. We didn't have to do that before because we just didn't have as many technologies. Now we're going to have like 100, so we're going to have to say this prostate is best for these things.
So you also talked at the meeting about how the new urologist should counsel the patient when they're early in their learning curve? Any words of advice on maybe the urologist that is trying a new technology and needs to tell their patient that I've done a number of these, which may be one. What is a good way to do that?
Yeah. I mean, I think if I were counseling somebody who's just starting whole up versus me after 20 years now deciding to pick up resume, I think that's a very different sort of counseling. There's a different level of confidence that I have in just that space, right? Um, I I think the most important thing is transparency and being committed to patients, right? I also think that you should not try to convince somebody who feels unsettled about it to do what you want because they're the right patient for what it is you need. So I do think it's a mix between being honest, but also telling them that they're going to be well supported and you're going to follow their course and actually follow their course. Like you're going to have to spend more time contacting patients and being in touch with them, and being available when you're learning something new, and if it's not going well, you need to be there for them. You need to understand. I did a new technology recently and my first couple didn't go well at all. The later ones did, but they believed in me and had faith because I was doing this journey with them and I exhibited as much agita, if you will, when they weren't doing as well. And I think they feel then that you're advocating for them and you really do want what's best for them. And if they develop that kind of trust, and you don't have had to have seen them for 20 years as a patient to establish that, it's that first visit. You can do that in that first visit, by showing humility in addition to the confidence. So I just think the biggest thing is really commitment and transparency, and selecting the right patient. I mean, my God, I mean that is probably above all everything, is making sure that you are selecting something for success, especially when you're first learning it, right?
But I think also, Lori, it's each of us have our first patient. I mean, just the
Absolutely.
nature of the beast. It's just a question of the confidence that you have as well as the patient has. So, can you really learn something from a computer video as opposed to going and watching some people? For example, you came over and watched us do aquablation. It may not have made you better or worse, but I think it gave you the more confidence that when you did your first one, you had seen it. And I think that's important too. That there's one thing to read about it. There's one thing to virtually simulate it, but when you see it in action, you look over someone's shoulder who has done more of them, that gives you more confidence, and that can be transmitted to the patient as well. Because each of us are a patient, and if it's not, there's someone's father or grandfather is having, or son or whatever is having that BPH procedure, and you would want for them the same thing that you would want for any other patient. I think we should keep that in mind as well.
And that's really that commitment, right? Like when I went and watched Steve, I was not looking to industry to answer these clinical questions for me. And I think that can get lost sometimes. I was able to go to Steve, who he's not there to sell the technology. He's there to help me get through this procedure when I start to adopt it safely, because he doesn't want me to call him 2 weeks later and say, okay, I just did mine and they were a complete disaster, right? Like, he's as committed to me having success as well. And so I definitely think that when you take up a new technology, you need to be willing to put in that time and commitment to do exactly that. Like, took a day out of my schedule, went down. Steve was able to help me get in there, and it made a huge difference. Huge difference. It was, for me to be able to ask questions when something looked a little, what are you seeing there? And having that availability to somebody who can be there as a preceptor, mentor, whatever.
It was great discussion. So in the last 2 minutes, as we wrap up today, I really want to talk about what the key next steps of investigation you envision are necessary to further enhance the evaluation and management of patients with symptomatic BPH. And Dr. Elterman, I'm going to ask you to go first.
Well, I think that there was a lot of discussion about what is a clinically meaningful outcome. What is important to the patient? What's important to the physicians? We have all these different technologies, but there isn't a set standard metric to assess them. And especially these are newer technologies. So these new minimally invasive treatments, these MISTs, they're not medications, they're not resective surgeries. So what should they be compared to? Or should they be compared to anything and sort of stand alone? So I think the future of this is understanding, as Lori said, I think, the patient selection, the type of prostate, not just the volume, but the length, the anatomy, and which technology, which treatment fits with which prostate, and then how do we even assess those in sort of a meaningful way. And that was a lot of the really excellent discussion that occurred at the Society of Benign Prostate Disease, the SOBPD, which I'll put in a plug. Everyone watching this webinar or podcast should please join. But that was a lot of the discussion was, we have all of these technologies. Let's take the time to assess them so that our patients get the right one.
Dr. Kaplan or Dr. Lerner, anything else to add on that front?
I'll just make a more holistic comment, and I'll let Lori make the last comment. And I wear this tonight on the BPH hat, but also as chair of research. We have to understand who our customer is, and the industry needs to do that as well. We're not the customer, it's the patient. And what we should be looking at in the future is to enhance the patient journey and to make their, not just treatment, but their post-op care and how we take care of them important. That's the unmet need, not just in BPH, not just in urology, but in medicine. We forget that's the person. And we have to listen to try to make their lives easier, their recovery easier, their post-operative care, and frankly, how we manage them in the future. And that will be the challenge. I would say that using digital technology will help with that. So it's beyond BPH, but I think it's the opportunity as well.
I think at the end of the day, we just need to do the right thing, right? Like it's just that phrase as old as time, do the right thing. And I think in BPH, we see people try to fit things into a BPH model, and we may very well miss things like nocturia. People are not necessarily taking advantage of tools of a frequency volume chart. I don't know how many of you guys have patients that are on Jardiance, but Jardiance leads to significant glucosuria. And we have had a huge uptick in patients with having more frequency, which, that frequency may very well be related to their glucosuria. So it's also coming back to the roots and saying, taking that time to understand, are we treating the right disease? And looking at their medications, which we like to say, I say it all the time, I'm just a stupid surgeon. But if a patient's on a steroid taper for COPD, that may be why they're having increased urination. Like taking that extra time to understand the whole picture of the patient, and are we barking up the right tree, and should we be sending them for a sleep study or something, or altering their meds before we're just jumping into a procedure for, oh, this must be BPH.
Excellent points by everyone, and I wish we could talk all night because I'm learning a lot. I know, and it's just a lot of fun to hear everyone's thoughts. But Doctors Lerner, Kaplan, and Elterman, thank you for your time and this excellent discussion. And I'm sure the viewers will truly enjoy this. So have a great evening, and thank you live from the AUA.
Thank you, Amy. Great job.
Bye.
Thank you. Thank you, AUA.